Hi, welcome everyone. I'm Dr. Keisuke Hata from the Department of Surgical Oncology at the University of Tokyo in Tokyo, Japan. Today, we have Dr. Takahide Shinagawa, the first author of this manuscript, who is also from the Department of Surgical Oncology at the University of Tokyo. We're here to discuss his recently accepted manuscript in gastrointestinal endoscopy titled Pinecone and Villi Patterns and Endoscopic Signs Suggestive of Ulcerative Colitis-Associated Colorectal Cancer and Dysplasia. A recent randomized controlled trial comparing targeted versus random biopsy by Professor Toshiaki Watanabe proved that targeted biopsy can detect a comparable number of neoplastic lesions in patients with UC when compared to random biopsies. So, I think many endoscopists will now want to know how to target neoplastic lesions. What motivated you to do this research?
Thank you for your kind introduction, Dr. Hata. For the first question, how to survey colorectal cancer is one of the main problems in managing patients with UC. Currently, colonoscopic surveillance is a gold standard. However, unlike sporadic cancer surveillance, UC-associated colorectal cancer is difficult to detect due to background information and the flat configuration of the tumor. It is true that RCT has proven that targeted biopsy is as effective as random biopsy when performed by specialists. However, for many non-specialists, targeting neoplastic lesions in surveillance colonoscopies still proves difficult. Therefore, we consider it vital to elucidate suggestive endoscopic findings for neoplastic lesions. If we can enumerate key findings for targeted biopsies, it may lead to early detection of neoplasia in patients with UC not only by specialists, but also by non-specialists. This is a core motivation to conduct this research.
So, what is the study design like?
This study consisted of two parts. First, we used stereomicroscopy for surgical specimens from 15 patients with UC, containing a total of 25 neoplastic lesions. We created 769 magnified images, including 509 images with neoplasia and 269 images without. Two evaluators independently evaluated each image for Kudo's pit pattern classification, type 1 and 2 for non-neoplastic pit and type 3 to 5 for neoplastic pit, as well as for surface morphology, such as pinecone or villi plans in blind to pathological diagnosis. The correlations between surface findings and pathological diagnosis, neoplasia or not, were analyzed and diagnostic values were calculated. Second, we validated the results using magnifying colonoscopy images from 26 patients with UC with a total of 39 neoplastic lesions with correct pathological diagnosis for each image. Again, two evaluators evaluated the images and correlations between endoscopic findings and pathology were calculated in the same way.
Okay, so you first used stereomicroscopy for surgical specimens and then validated the results using magnifying colonoscopy. Is that right?
That's right.
What are the main results of this study?
When we combine two matched cases by two evaluators, neoplastic pit pattern such as Kudo's type 3 to 5 showed a high specificity of 90% and a high positive predictive value of 93% for neoplastic lesions. Pinecone and villi plans also showed a high specificity of 97% and high positive predictive value of 92% for neoplasia. These results indicate that endoscopic findings such as neoplastic pit patterns including pinecone and villi plans should be biopsied in surveillance colonoscopies. Validation by magnifying colonoscopy showed a similar trend. However, some flat neoplastic lesions presented as non-neoplastic pit patterns in both stereomicroscopy and magnifying colonoscopy. It is important to be cautious at this point, since there could be some hidden neoplastic lesions and almost normal non-neoplastic surface structures, and targeted biopsy alone may have some pitfalls in overlooking such lesions. Our sub-analysis for flat neoplastic lesions with non-neoplastic pit patterns showed that redness was one of the most supportive findings in detecting such lesions.
So you're saying that the PIP pattern is useful but not perfect. So you should also be careful at the red surface patterns, even if it's non-neoplastic PIP pattern.
Yes.
Then how can you apply this study to the clinical practice?
Our results may add some supportive information on targeted biopsy in surveillance colonoscopy for patients with UC. Kudo's neoplastic PIP pattern and morphological changes such as pine cone and villi patterns are very important endoscopic clues for targeted biopsy. However, it should also be noted that they are not findings exclusive to neoplastic lesions. The sensitivity was quite low in pine cone and villi patterns, 21%, and not as high in neoplastic PIP patterns, 77%. Additionally, there could still be some hidden flat neoplasia without any neoplastic PIP patterns.
So do you magnify the whole surface of the colon when you perform surveillance colonoscopy?
Well, performing a magnifying colonoscopy throughout the total length of the colon will take too much time. Therefore, in real-world practice, we do not necessarily magnify the whole surface of colonic mucosa. The resolution of recent colonoscopic images has become higher and higher. Therefore, even normal colonoscopic examinations without magnification could be expected to detect rough images of type 3 or 4 PIP patterns, including pine cone or villi patterns. After detecting suspicious lesions in routine colonoscopies macroscopically or pathologically, cross-investigation via magnifying colonoscopy focusing on targeted lesions might be reasonable. In that sense, pine cone or villi patterns detected by non-magnifying colonoscopy could provide key findings for targeted biopsy.
So do you think you can detect the majority of neoplastic lesions in the way you mentioned earlier?
Unlike sporadic colorectal cancer diagnosis, PIP pattern diagnosis and surface pattern alone are not the panacea for surveillance colonoscopy in patients with UC. Especially for those with active chronic inflammation, performing random biopsies from reddish areas in addition to targeted biopsies may aid in the detection of more hidden neoplastic lesions. I hope this study can shed some light on creating a better understanding on the morphology of UC-associated colorectal cancer.
Thank you, Dr. Shinagawa. Thank you very much, everyone, for listening.